Hi, welcome to Everything Digital Health. I'm Marcus Bohr, and I'm happy to have Thomas Beale on the line with me today from the United States of America. Thomas is one of the founding fathers of the openEHR community, having been fundamental to inventing the standard itself. So I'll hand over to Thomas to sort of properly introduce himself now.
Well, I'm Thomas Beale. I'm originally an electrical engineer, and I started life in real-time distributed systems, the kind of things that control power stations and nuclear reactors and gas pipelines and all those kind of things. So my starting point in life was high-quality, bulletproof software that really couldn't fail, because if it did, well, you don't really want a nuclear reactor blowing up, do you? Or people dying on a train or other sorts of things. Anyway, I did that for about 6 years, and then I went traveling through the US and ended up in London. And in 1994, I ended up with a project, a European project called Good European Health Record, which was run by Professor David Ingram at Barts in London. And I'd never had anything to do with health IT or e-health until then. And that was a dream, in retrospect, a dream project to fall into, because it had partners from, I think it was 8 countries total, something like that. This is 1994, so this is framework 3 of that sort of funding framework system of the EU. And
Right.
so I ended up working with a whole bunch of MDs and nurses and other sorts of health professionals who had put together a very nice exposition of the needs from a technical point of view of information in healthcare, and how computerization could eventually be used in healthcare. And so that's how I got into e-health. And I've done lots of other things since, including working for large financial organizations and all sorts of things in Australia, and consulting for various. When I learned enough about health IT, where I could even consult on anything at all, which takes many years to figure out what on earth the domain is really about. But I did quite a lot of consulting work for ministries of health in various countries around Europe, Australia, even more recently in Jamaica. So fun places to visit. And then
Cool.
in about 2000, got involved with helping set up openEHR, which officially was created in 2003. Anyway, I guess we'll talk about openEHR. And I've been pretty much solid on e-health development of various kinds and standards involvement and all that sort of thing for last 20 plus years. And I'm currently in the US. So I've spent 20 years actually working on setting up building specifications and either writing them or facilitating them. So people tend to blame me, which is fair enough if something's wrong in one of the specifications, but actually there's a huge list of people who've contributed to them. And if you look at them on openehr.org, the specifications site, you'll see lots of names in the revision histories, and anybody who's contributed anything has got their name in there. But yes, so I did a lot of that, and here we are. I've been working for a couple of years in the US, and I'm probably about to head off and do something new, which is unknown. So that's where I'm at the moment.
Cool.
And I should probably
So
say I'll just add one more thing for people who might be interested, because there's a lot of people in this domain, including you, Marcus, who are kind of what we call geek docs very affectionately, which means that they've got a clinical background as well as a IT background, by whatever means. So I'm not one of those. I achieved my domain plus technical schizophrenia by hanging out with a lot of doctors rather than actually being one myself.
Well, I guess like I've learned the stuff that I know about computer stuff, computer science and software development, by doing the reverse, which is hanging out with developers and computer scientists until I sort of learned enough to be dangerous, which is kind of how I feel as that I am in terms of being a developer. So openEHR is a multi-decade project in the open to develop specifications. That's right. So we have a series of specifications and some implementations now of something that you can be used to build an open healthcare record. That be fair summary?
Yeah, I mean, the main differentiator really is that it takes the semantics and the knowledge of the domain seriously. So if someone like you were to just put on your, GP hat and think about, what's it like to see the usual stream of patients coming in the door at a, practice and thinking medically, you've just got a whole ton of knowledge and, cognitive, pathways that you use. You don't even think about you've got lots of experience, and all experienced clinicians, whether they're midwives or nurses or allied health or whatever, they're all the same. There's a massive amount of knowledge which gets brought to bear, so you can investigate somebody's problem. You can start to think about what you might think about diagnosis, or at least sort of roughly categorizing them and assessing them in some way. And then you want to get to a decision. Are you going to do something, some sort of intervention? And then if you go down a pathway, could just be referring them to specialist, or something that you can manage yourself. But all of that involves a huge amount of knowledge, which well, it's the kind of stuff you find in textbooks, and it's people have learned it all the way back in med school, or nursing, or whatever other educational history. But subsequent to that, of course, all health professionals have done all sorts of residencies and so on, and eventually, after many, many years, you do what you can do on your own as a fully blown professional. So openEHR takes that seriously, rather than trying to do the usual things that you would find in an IT textbook, which is have the IT people somehow go and ask people from the domain, about some use cases, or about how things work. And that doesn't work, because IT people, generally speaking, that there's no way they can really grasp what goes on in the health domain. They don't even know what a guideline is, for example. They don't know what DRGs are. I can just mention a whole lot of things that you would be familiar with, and they don't know what they are. And in fact, it would be easy for you to mention things that I'm not even familiar with if you just dig deep enough, even though I've got quite a lot of experience with medical terminology and general knowledge. So what you have to do is think, okay, if we're going to get the way that people work and how they think and how they treat patients into computer systems, we're going to have to model that knowledge, make it computable. Where are we going to get that knowledge from? I mean, who's going to articulate it in a way that computers can understand using some tools? It's going to have to be people from the domain, plus or minus, what we usually call clinical informaticists or medical informatics experts who've done deep study, and often are, ex-MDs or ex other sort of healthcare professionals. And so openEHR takes that seriously. So there's a pathway to create models. Mostly at the moment it's data models, but in the near future we have to be contemplating models of process. So that means things like guidelines and care pathways and decision pathways, treatment decision pathways. And if we can make that computable, then we can contemplate how computer applications and also the data that's in systems might actually start to properly reflect what's really going on with the patients, and the details of recording of information, and tracking patients over time, and at a level of precision that corresponds to what's in the minds of people who do the healthcare. Because too often they're faced, people that you would have found this in the past at least, you've been faced with applications running on some computer. You just thought, oh my God, this is nothing like what I would build if I were in charge of doing this. And it's missing sort of stuff, or it's making you doing 50 mouse clicks to do the simplest possible choice of a term, or all the usual problems that docs and nurses complain about, usually justifiably. So that's the differentiator with openEHR. It's a model-based platform, and there's a system for building those models and involving people from the domain to do it. And the resulting systems, if they're better than other kinds of systems, that's the main reason. It's because at least they've got a shot at representing at a much higher fidelity, and also in a very generalized way. There's some IT tricks in there as well that we've used. Yeah, but that's the
Yeah.
difference.
So that's a major advantage of doing it this way, is that once you've gone through clinical modeling, so you're essentially giving the keys of the modeling to the clinicians, then you end up with something that's technical that you can give to developers and they can build systems with. And that
Yeah,
if you've got multiple systems using the same technical artifacts to model, for example, the concept of a clinic visit or the concept of a blood pressure or the concept of a CT scan, then those become interoperable. So you could take that concept where it's been modeled in one system, even in one type of database, and move it wholesale to another type of database in another hospital with another computer system. But they've both represented that clinical concept in the same way, with the same fields and the same validation limits and the same units and all that stuff.
yeah,
So it
exactly right.
creates interoperability where there was none before.
Yeah, so
So
we can
that's,
think of it as a sort of
yeah,
single
that's cool.
source of truth modeling approach. And it's
Yeah.
interesting because
And
critics say things like, "Oh, there's no way you're going to get agreement on any of those things you just mentioned. What is the data of week 36 of a pregnancy? What's the blood pressure look like? What's a Glasgow coma scale recording in ED look like?" But if you get the people together and you create community, so this is an absolutely essential element, has been the creation of the modeling community. And there's other people, as you've had some involvement in it, and
yeah,
but it's been
yeah,
done by clinical people. um, you actually can get close to a single source of truth. I mean, you know, we have to live in pragmatic reality, so everything's got to be, you've got to use something that's good enough. But it turns out that actually the model of blood pressure and the model of many, many, many other things, all the way through to oncology, T&M staging, or whatever, pretty much the same across Western medicine, with variations, but the core is very, very much the same. And Western medicine is pretty globalized these days. So if you get the community together, and it's been proven now. I mean, there's been 10 to 15 years of these sorts of models being percolating up from more local places, jurisdictions, and so on, into an international model repository, and that's what most people use. And there's probably 85% of that, or I mean, there have been studies that shown that new projects tend to get about 70% reuse, that is straight out reuse of the definitions of the clinical data. And depending on what they're trying to do, they might have to invent 30% themselves, but that's probably reducing because as more and more of medicine is covered, and also peripheral areas peripheral to medicine, just like public health and whatever else, the coverage is there. If it's been done once, it can mostly be reused, and the change rate on those models is to do with medical science and new approaches to new logistical approaches to care, maybe. But generally speaking, it's medical, clinical, public health um, improvements over time.
yeah, yeah. That's another advantage there, is that it reduces the duplication of effort. So if you're building a new computer-based healthcare record and you can already get your data modeling, 70% of it is already in the international CKM, you can just adopt those data models and you've saved yourself all that complex and gnarly work trying to work out what the reference limits should be on various uh, parameters that really, that's none of that is something that you particularly want to care about when you're building an electronic healthcare record. They have to be correct, but you want to be able to sort of adopt somebody else's standard and say, great, well, this is all done. Because what really differentiates you in the marketplace as a new EHR is the usability, it's the features, it's the things that you can do for patients and for their caring clinicians. Nobody needs to care about the data model. It should be such an infrastructural layer that we can say, yes, those are the railroad tracks, build to that gauge and your train will work. And that's what we hope to do with this project, really, isn't it? It's like internationally agreed standards for every possible clinical concept.
Yeah, well, so there's another trick that we use there, which you of course know about, which is the separated, so the layering of the information models, so that there's a base information model that in the openEHR community we tend to call the reference model, but it's what most IT people would just think of as the hard information model / data model. So many people would think in terms of a database schema. But that model is very general, and it knows about things like clinical data types, quantities and coded terms, and some sort of useful data structures. And it has a generalized concept of what's an observation, like a blob of information that represents various kinds of observations and other sorts of things. It knows what, it's got a concept of a heading in the sense of headings on paper in the, old school form-based notes and so on. But it doesn't really go beyond a basic set of concepts. And all of the clinical semantics are actually modeled in a higher level that isn't in any database schema or software. It's all injected into the system. Or, I mean, you could build an application that hardwires certain knowledge of certain things. If you had an application that had a screen representing Glasgow Coma Scale, well then, I mean, your screen is just for that. So it's probably going to have some sort of direct knowledge of a model of Glasgow Coma Scale. But the models of any of these things, blood pressure, GCS, everything all the way through medicine, are all a second level of models, which we call archetypes. So what it means is that at the DB and back-end level, the data in an openEHR system running in Norwich in the UK, or wherever it might be, and one running in Slovenia or Turkey or Korea, it's exactly the same. And as long as nobody's made any errors in their software, their back-end software of each systems will understand the other system's records. And there's a bit of complexity about how they would understand all of the semantics, because you might imagine if somebody brought their records somehow from, let's say, Korea to a British system, and the backend would understand all the structures and the quantities and the coded terms, and the text might be interesting because obviously the text might be in Korean, or that could be in English as well. But if it can get its hands, if the British system can get its hands on those models, if indeed the Korean system has used other models different from the ones that are in international use, which is unlikely, it will have used some of its own models and probably just used the same blood pressure model as everybody else with the Korean translation, which we have. So it's pretty interesting because all of the openEHR data all around the world is automatically interoperable, or very close to fully interoperable, across any system that it might be ever sent to or shared with, plus or minus the language translation question of narrative text.
Wow.
So that's a pretty powerful thing. It also means that the back ends, the things that vendors have to build, they don't have to know any clinical models in advance to build a backend. They can build an empty backend. It just knows about this reference model, and they can, the backend can kind of get filled up when it's in production, being deployed somewhere. So that gives you a very nice, a huge amount of stability, and gets you out of ever having to do, gigantic data migrations, which are very common exercises in the usual EMR products, or else just being blocked from making changes to the database because nobody knows what the consequences are going to be. So that's an important characteristic of an openEHR system, is this separation of the domain semantics. The computable representation of domain semantics isn't part of the actual database schema or the backend software. It's another layer that's injected and all dealt with within the system.
That's cool. So that also must make it relatively less work for a vendor to build something like an openEHR backend, as in that the amount of hard-coded kind of concepts that the backend needs to understand is limited down to just sort of the reference model, really.
Yeah, that's right. I mean, I think the first build, there's other things you have to take care of, but it's a different category of system. So the first build, it's still going to be a fair bit of work, because you've got to take care of other things like proper version control. So that's a feature of openEHR, and audit information, and there's all sorts of technical things you need to take care of. But you've only got to take care of that once. you've only got to take care of, semantically, you've just got to take care of these different, data types, and a few generic structures like I mentioned earlier. And you can concentrate, a vendor can concentrate on making the back end, on the performance and the security and the, making it cloud capable, or, doing other sorts of tricks. But this is all engineering stuff. So, and that's just an
Mm.
independent pathway. If there's other groups completely, like your country's jurisdiction or just a customer in another country who's working on, I mean, it could be anything. It could be diabetic pathways for a Polish region or something, that you don't know anything about. Your backend is going to work perfectly well as long as they're using the openEHR modeling tools to do all their stuff, and you're obeying the specifications for the back end. It's just going to work, and you don't have to do any more work to do with the addition of any domain semantics, any of these models. It has no impact whatsoever on your back end. So that is a good thing, and it means that you can kind of employ engineers who really, they're probably going to be Java or C# or one of these kind of typical back-end type of languages and technologies, and they can just go to town on whatever they think is the best possible database. And if they want to do the most modern stuff like Polaris and Iceberg and whatever, go for it, and they can achieve engineering quality characteristics of systems. And like you said earlier, they can just not worry about the domain information models. Somebody else will do that. It'll just work when the thing is plugged in.
Well, that is the kind of power of it, really. So when we talk about plugging these things in, where are we going to get them from? So if we have got archetypes that we want to share, how does that all work in the openEHR community?
Yeah, well, I mean, that's, I'm one of the people, well, I guess I'm the original author of the spec, and the archetype idea came from an idea I had, but it's one of those things I think that just percolated out of, a bit of lucky thinking and a little bit of out of the box thinking. But of course, it's everything like that is on the shoulders of others, and it's a bit like all of the nice, wonderful discoveries in the history of science and physics, all that kind of stuff. It's amazing how different people in different countries thought of a very
Everything is
similar
built
thing
on something else.
time. Just famous example is Newton and Leibniz worked out systems of calculus at the same time. But anyway, so we got lucky with an original idea, and that meant that we were able to build a language to represent these models that would have a lot of flexibility, but also a lot of precision, so that you could build a model of the possible elements. Let's just stick with blood pressure. The possible elements that you might want to record, which is obviously things like systolic and diastolic. But then somebody will come along and say, well, do you realize most machines these days would use a thing, and people as well, use a thing called MAP, which is mean arterial pressure, and there's a calculation relating systolic and diastolic. And then somebody else comes along and says, well, there's a thing called pulse pressure, and that's how we use that. And then there's all of these bits and pieces to do with, well, we need to know the state of the patient, like were they, running, sitting, standing,
Sitting,
exercising,
standing, lying.
all that stuff. That
Mm-hmm.
matters a lot, as you know perfectly well. Every time you do a blood pressure in the GP office and the person is in a different position, it's like, well, we better do that one again. So these are all things that you can possibly measure, and you use some of them. You don't record pulse pressure and systolic and diastolic pressure. You use the things that make sense. So we had a language to write things like that, but way back sort of 15, or I guess it's nearly 20, probably 15 years ago now, we didn't have any models except for a few that me and Sam Hurd, who's a well-known doctor in Australia, who was one of the other progenitors of openEHR, he and a few other of his medical colleagues built a few, and he actually wrote a tool in VB, and typical doctor hacker, but it was brilliant because he understood exactly the semantics. And so the thing we had to get to was what I mentioned earlier, was a community and a credible repository of models that essentially the whole world could look at and go, well, you know what, that is actually a pretty good model of blood pressure. Everything's in there that we need. And to get to there from the starting point obviously entailed the creation of that community. So that's it's not really a technical question, it's a human question. And there is a chunk of technology in there, and there's a site called CKM, or a thing called CKM, it's a product, Clinical Knowledge Manager. And there are various CKMs in various places, but there's one at openEHR.org/CKM. And that community probably has taken 15 to 20 years to create. And if you go online there now, you can see that there's, I think it's 3,500 subscribers. So these are all the medical doctors, nurses, all sorts of other health, health admin type people, or public health, and all the usual degrees and knowledge that the whole gamut of healthcare, and a lot of clinical informaticists who just specialize in understanding healthcare if they're not themselves, haven't been doctors or nurses themselves. But so that's a big community, and people like initially Sam and Heather Leslie, who's another doctor from Australia, and Ian McNichol, who's a great open-air pioneer in the UK, and many other people. I mean, I won't get through all the names, but they've seen the promise of what it would take, and they realized that you had to create this credible, both a repository and a community. So that's the people. And, they built it over, 15 years of hard graft, basically. But one of the interesting things they realized is we can't do this in a sort of standards model where people just, take out a week out of their expensive, busy clinical schedule and just fly to some city, to an HL7 meeting and just talk around tables and, argue about the model of blood pressure. I think it was Heather Leslie who, I remember her saying to me, it must be 20 years ago now, all we need is to get a half an hour per week for a few weeks from, whatever kind of person, a general practitioner or an oncologist or whatever we're modeling. We just need little chunks of time, because they know exactly their data. They don't have much time, but if they had a way of, providing an hour of expert input, and they had a tool where they could just review, for example, the current model for, for some cancer staging workup or just whatever it could be, and they could just comment quickly, and they could, have their correct attribution and all that sort of stuff. That's the sort of tool that she and others envisaged, and that's what they actually created, which turned into this thing called CKM, Clinical Knowledge Manager. And really what it is a thing that enables a massive community around the world of all these different types of healthcare professionals and informaticists to spend just little chunks of time, very, very focused on models that they know about, and they might spend 15 minutes and look at it, let's say a model of tobacco use or something like that, which is obviously a common thing that's a common questionnaire kind of thing that's asked in general practice or elsewhere. And they might just look at one thing and they'd say, well, actually in our clinic we have another thing or a variant version of this, and they put some comments, and that's how all that has come into being. So it's completely crowdsourcing, and we're not even using AI. I mean, we probably should be, and that's that'll be the future, some sort of AI assist. But the ability to use those little chunks of time focused onto models of specific areas of medicine, that's been a complete, I mean, nobody's done that before, to my knowledge. And all of the other standards development organizations' attempts to do that really aren't very good. And that's not a criticism of the people or the intent or anything like that. It really isn't. It's just that it's a guaranteed outcome of trying to do it in committees and people going to so many meetings per year and all that sort of stuff. It's the wrong way to get the time from those people. You've got to get much smaller chunks of time so that it doesn't interrupt their their professional work, and yet you get their specialist knowledge. And that's what's happened. So it's kind of incredible, because the whole of open is a kind of, there's a whole lot of engineering specifications that you can build things from, and then you've got this whole other community of people who've built models and just keep building models and covering more and more of medicine. So
it's a very open source model of doing things, isn't it? It's very nice and open. And I think the requirement for only just little bits of people's time sort of makes it more amenable to the average clinician who
Yep.
might want to become involved in this and just make comments, as opposed to when it does, if you've got the opposite sort of committee sitting standards development, that kind of requires people who've given over a significant proportion of their career time or their working time to this standards definition type work. And that attracts not necessarily the wrong people, but it attracts a different kind of person than your grassroots everyday clinician. And when it comes to data modeling that works for everybody, we need to attract the grassroots everyday clinician. We need those people to be the ones who make the decisions about what the data models look like, not necessarily people who are a different kind of mentality. You know, they're often, you know, the kind of archivist mentality that wants to think about terminologies and wants to think about finely leafed fractal data models that become at some stage, you know, kind of impossible to implement. We need the practicality. So that's
Yeah,
great.
well, so one of the interesting things about the modeling pathway, and again, this is absolutely nothing to do with people like me on the engineering side, and I think it might have even been Heather or Sam, I'm not actually sure, I don't remember who, but it was realized pretty early on, you had to get to the, as close as you could to the sort of cognitive level of doctors and, you know, any other type of professional who've never ever seen. They don't know what HL7V2 is. They don't know what lab message looks like in terms of its data. And why should they? I mean, they just want to practice medicine and, you know, do good patient care. So the earliest, like the beginning representation of the open-air clinical models are actually mind maps. Now, most people can get their heads around mind maps, and if you know, it's just a sort of spider diagram of, you know, bits and pieces and breaking down in a hierarchical sort of or fractal fashion. And I've actually, you know, just sat in on a few workshops where people have worked up things like, you know, tobacco use data and some other things that tend to get used in workshops. And there's lots of data points. There might be 50, you know, 25 to 50 data points and those sorts of things. And the clinical people who have, like I say, they don't know anything about openEHR. They've got no clue what the reference model looks like. They don't know anything about HL7 or anything else. They get right to work very quickly because what's a mind map? Well, you name each node. At the peripheral nodes, you put some sort of data type, but clinical people understand the difference between a quantitative and an ordinal, you know, of the sort that you would have in an APGAR score. They know what 0, 1, 2, that's a different thing from a normal quantity. They know what a coded term is. They know all about codes because you have to know that in clinical medicine. So that's about all they have to know, and they can just talk about, well, you know, what's the sort of hierarchical structure of such and such an area of medicine, and you know, they work out a logic that makes sense from the domain point of view. And because they start out with those mind maps, there's almost no barrier to getting involved pretty well instantly, and they don't have to really learn anything. Now, people who go a bit further and they, you know, become the real true geek docs, so they will have spent a bit of time with the archetype modeling tool. So they have to learn a little bit more, but it's actually not a great deal more. It's still sort of pretty much a mind mappy kind of feel. And
Yeah,
that has actually enabled grassroots clinical, you know, you can just get the person who knows everything about, you know, tobacco use or, you know, substance use or whatever, who knows zero about health standards, get them involved and they'll just tell you everything they know and you've got a place to put it. And they can even use these sorts of tools themselves and they can, you know, just go straight to work. So it is pretty powerful in that
it's surprising,
dimension.
yeah, how quickly it's surprising how quickly clinicians can get on board with it. And as you say, there's a learning curve, but the barrier to entry to just get started is quite low. Like you say, mind mapping, some of this can be done with pen and paper in a workshop and then can be
Yep.
digitized later. And so they're getting on the escalator at some point, and then as they do more of this, they'll learn more about the reference model. They'll learn more about terminology bindings and the things that become a little bit more tricky in the modeling space. But then we've got we have more senior and more experienced modelers out there who can help with buffing a model to finality. And we've got the international community as well, where you can put something up there on CKM and say, well, this is my first go at it, but I want some people to sort of kick it around a bit, find the gaps, improve the way it works. And I think that's
Yeah, well,
one of the
and one
nice
of the other
things
things
about
is
the standard.
having good discussion groups for those clinical people to do exactly what you were saying, essentially to learn, because there are nuances. Eventually somebody says, well, do I need a data point to record, the time of the observation? You don't. It's in the reference model. And you can click a button on various kinds of tools and it'll sort of show those things or hide them. So there are things you have to learn, and there's always edge cases. And then, people get into the complexities of things like questionnaires or scores, but where you're allowed to not answer some questions, or maybe some question might not have a numeric score, but it could have a text alternative, and all the messy stuff of medicine. So there's a very good online community on the Discourse site. And for listeners, Marcus was the one here who actually convinced us to start using Discourse, because he's set it up for lots of organizations, including parts of the NHS.
Well, I think anyone who knows me finds that within a few minutes of meeting me, if I haven't mentioned Discourse, they check my pulse, because I tend to find whatever the problem is, the solution is a forum.
Yeah, well, it really, but it has to be a good quality forum, because there's lots of bad, not wanting to mention any of the big tech attempts at teamwork on certain types of tools. But I have to say, as a tool, Discourse has been very good. But anyway, we're not here to talk about that, I guess. But the point is that it's enabled the community to talk to each other, and it allows you to divide down sort of topics, finding enough that people can separate out discussions on, let's say, scores like APGARs and GCS from something totally different, so that people can get together and they sort of train each other. And like I said, everything so far has been done without any generative AI, which a lot of people think, oh, we can solve all this with AI. Well, it undoubtedly will provide assistance, and we're sort of, there's a little bit of background work going on to sort of go that direction. But I have to say, I don't know that we're ever going to replace that grassroots kind of community. It might be what one hopes, that for a given size of the grassroots community, it might just produce, maybe it can double its work in the future. Who knows what the output level might be able to be greatly increased. But I think it's going to be needed.
I've certainly had, in the last few months, really since kind of agent mode on VS Code, the ability of generative AI to be genuinely helpful in a very accelerative way has transformed. That's just happened very recently. But you could imagine a sort of AI assistant to a modeling tool, which might help with, for example, spotting when you've used a date time field that you didn't need because it's already in the reference model. That kind of stuff could absolutely be imagined, where the clinician is still driving, but this is a kind of sat nav on top saying,
it's
steering you to the areas where you need to, steering you to the areas where you're going to need to put in the more thought, and also steering you away from the rocks kind of thing. I think it's absolutely easily to envisageable now. I mean, that feels like we've covered a lot about the sort of nuts and bolts and the sort of underbelly of openEHR. What do you see as the challenges for the future for openEHR, in terms of not so much in adoption and things, because that's an ongoing kind of war of attrition really, but technical things? What's coming down the line? What would you like to do with the standard?
I mean, my personal interest is probably exemplified by something a doc said to me in Lund. It wasn't the only time. I mean, it's obvious, but in Lund in southern Sweden, we're at I think a SAN or ISO conference of some kind, and he was a member of the audience, and we did some presentations on archetype and all this clinical modeling stuff. And at a coffee break, he said, Thomas, this is really fantastic stuff. I can see, we don't have any ability to model this stuff like this, except as forms in some particular brand of EMR product. And then you go to the next EMR product and you've got to do it all again. He said, that's nice, data's good. But we clinicians, process is what we think about, because we think over time, what's the temporal pathway, the care pathway of a patient, because we're thinking about resolving an illness, or we're thinking about, well, what's the next series of appointments that they might need, or they're on a treatment pathway. Everything's unfolding over time, and that's how they think. And I said, well, yeah, I'm aware we need to, we've got to have a computable representation of process as well. And that's, for me, that's the thing that I think's one of the key important areas for the future. I've written reports, for example, for the VA, the US Veterans Administration, for their potential use of process automation, and for other organisations. And most organisations have heard from Karolinska Institute in Sweden recently, and most organisations involved in healthcare, either jurisdictional or the straight out providers, are thinking, how are we going to automate or do some process automation? So what does that mean? It means bridging the gap from, for example, guidelines. I mean, guidelines are partial processes for doing some pieces of work, and helping docs, like reminding them to how to navigate through past contraindications for certain types of treatment, or whatever, particularly for complex things. But it's bridging the gap from guidelines that are currently PDFs or website sort of just textual things. They're not computable at all, and they're not at all integrated into the EMR environment of the doc. So I think that's probably the key thing, is getting to a point where we've got a co-pilot that's a sort of physician assist. And when I say physician, it could be nurse, could be any other kind of carer. So a professional assistant, co-pilot of some kind, that's integrated into the IT tools, just the work environment. And it doesn't get in their way, because they know how to do their clinical care. But it helps them, if there's a lot of complex stuff they should be looking at, like contraindications for treatment, for thrombolytic treatment in acute ischemic stroke. It's a long list. Now, one of the problems in just human psychology is that it's known as the 7 plus or minus 2 problem. So it's the number of things that most humans can keep at the forefront of their mind and juggle at the same time. So really super smart people, maybe they can do 10 or 9. Let's say that's the 7 plus 2. But most of the time, it's roughly 7. Now, if you analyze a certain health condition, something that's a bit more complex, like acute respiratory distress syndrome, or sepsis, or acute sepsis care, or stroke, or whatever, there's just a lot more than 10 variables in play, and you're going to need help. And that's been established by people who've worked. I mean, they're well-known and highly published authors in the area of clinical quality, and who've built guidelines, from some of the big, US and European research hospitals, for example, and other sorts of institutes. So that's well known. So I think that area is what we need to concentrate on, and we need to make it so there's a few different aspects to that. There's a kind of process that's immediate clinical care. Like if you've got a stroke patient, there's a thing called the stroke clock, and it's kind of ticking, and you've got about 3 to 6 hours to do various things, but you've just got to move as fast as possible, because it's the later you are, the worse the outcome is. So that'll probably be the same kind of team of carers, just working flat out, trying to maximize the or optimize the outcome for the patient, and then they'll go home after work and they'll sleep well. But most healthcare processes actually are kind of long running things, and they're multiple appointments. And if you think about chemotherapy, where there's 5 week long administrations with a week break in between, that's 10 weeks of chemo. It's not going to be the same nurse or docs who review you, or it'll just be all different people. I mean, you might get lucky and maybe it's the same people, but it's unlikely. And then if you think about any just much more routine stuff, like just straight out general practice care, or taking your kids to the doc, or if you're diabetic and long term, sometimes outpatient of local hospital. I mean, these things run over months and years, and essentially forever. If you're type 1 diabetic, for example, who's going to keep track of where you're at in your care pathway? Who knows for sure where, does anybody know whether you even attended your last appointment? And actually, the only thing that's going to know that in the future is what I call the process-enabled health record. And that in the future is going to be the only entity that actually knows about the state of the patient over time, because there's no single human being involved. Imagine if you're a dialysis patient and you're just regularly going a couple of times a week or whatever to the hospital. I mean, over a 2-year period, you'll just have different nurses taking care of you. You'll be reviewed by potentially different doctors. I mean, doctors move around. They go on holidays. They do whatever.
Absolutely, they do. Yeah.
What entity is going to know where you're at? And what if there's a new, drug treatment, and maybe you're entered on a clinical trial? Who's going to make sure that you're, doing the new activities that the clinical trial entails properly, or that they've been done? And if you go back to the chemotherapy example, I mean, you really don't want to be messing up the dosing of chemotherapy or the administration of the dose. I mean, the doses is one thing. You can't get that wrong, because that's a calculation typically. But you need to know, okay, was yesterday's actual dose administered correctly? It might not have been, because the patient might have reacted and somebody might have decided to stop the treatment. But it might have been. You hope it has been. But how's anybody going to know? So it doesn't matter whether you're at the sort of acute end of care or this long-term routine stuff or anything in between. And also, the patient crossing across multiple care facilities potentially. And even worse, but also just normal, is comorbidities and so on. So we've got people with all sorts of different problems running at the same time. And so, that's the base level of complexity of healthcare, and it's just, built into how all the professionals deal with it. You've got to deal with it in some way. So I think that process there that's one of the main things, and one of the kind of killer statements of how important that is. Brent James, who's a medical doctor, and he ran the clinical quality care group at Intermountain Healthcare for, I think, 20 years. He said, and this is in other papers, it's not just him saying this, but he would go out and stage. Now, as an MD, you can do this, talking to other MDs, but at his training courses, he would say, ladies and gentlemen, we're killing people all the time. And quite likely, 50% of the things we do are wrong if we examine the evidence from the start to the end. Like if you examine all the cases and the progression of the case through the treatment, it could be that 50% of all medical professionals' actions, despite obviously best intentions and Harvard Medical School level training and all the rest of it, could be wrong. Now that should stop anybody in their tracks and make them think, my God, what do we do if that's really true? And there's another figure that says that I think it's about, it's in the hundreds of thousands, I forget, 300, 400,000 deaths per annum in the US. I think it's the third largest cause of death, has been estimated to be due to avoidable medical errors. So not people who were going to die anyway, and you just couldn't save them, the other kind, right? So it's like 3 747s, to use an old cliche, per day. I think it's an epic number of people. So that whole process area isn't just about tracking people over time, but it's also designing at least fairly evidence-based care pathways by reviewing 100 sepsis cases in a certain institution or doing whatever, and working out what things work and what things don't work, and then creating a co-pilot that will help docs and everybody else to just not forget to do something. And that whole area, I think, I mean, this is going to be very tough, because we've got to build this into the cognitive environment. It can't take over their the doc. The doc is still in charge, medico legally responsible for one thing, but it's just like you or me driving our car with Waze or Google Maps or whatever on. It's still you or me driving the car. I mean, it might say useful things, but you kind of want it to shut up at some points as well. And they are actually fairly well designed. They don't tend to talk too much. They do a little bit, but mostly it's an okay experience driving a car with one of those co-pilots. And we've got to make medicine like that, I think.
It's exactly what's needed. Is we need more just-in-time knowledge presented to clinicians to guide them through the medicine, which is now so complicated that you can't feasibly keep up with the rate of change of all medical knowledge that relates to the kinds of patients that you're seeing, even if you're quite specialized. And we need that kind
drugs,
of
can you?
change. Yeah. And but as you said, I mean, currently guidelines are authored as Word documents by bodies that set standards or guidelines around the world, and they output them as a PDF and they put them on their website, and they think the job's done. And we're going to have to really work hard, and this is a multi-decade challenge really, to change that approach, to say you need to be authoring things in some kind of computable way that we can both have a written output that you can read if you want to, but primarily that computable guideline needs to be almost a computer program that can guide the clinician as they're delivering the care to stay away from the wrong things and to go and do the right things. But we're going to there's an awful lot of work to be done there to convince Royal Colleges and the National Institute of Healthcare Excellence and things like that. How do we get them to want to publish guidelines in a computable form? But that's the kind of thing that, say, GDL and through openEHR can actually enable the process of. So
yeah, that's exactly right.
You could publish something like that as a guideline definition.
One of the beautiful things about that, actually, I think, is that a lot of guidelines, at least for sort of either acute conditions, things that really, if they're applied properly, they really have been proven to change outcomes. They might come from very well funded, places like Charité in Berlin, or UCLH in London, or Intermountain Healthcare or Mayo or somewhere in the US. Those sorts of organizations have got the money to have their own research groups and work out those sorts of things. I mean, there's all sorts of institutes as well, National Institutes of Health and cancer, and Europe's got many of those. But there's a lot of hospitals and other types of clinics just out in the middle of nowhere, and they can't do that. So if we can get it so that the guidelines that are produced by those centers of excellence are made into a computable form that can be consumed by affordable software that can be run anywhere, then docs who are just at the coalface of just rural Turkey or something, or wherever it might be, or in the US, here's Indian health. I mean, indigenous health's always just a tricky area. They get the benefit of that, center of excellence level of thinking, and they can just immediately apply it. And there's a kind of classic thing which you'll know very well, which is this cliche of supposedly 17 years. There's a famous paper way back when that says it's 17 years on average before the knowledge of how to do something properly, a guideline has been developed to when it actually gets deployed out there at the the front edge of medical practice. I mean, 17 years, even if it was 5 years, that's ridiculous. It's got to be 5 weeks, or, why not just as soon as we've got it, have a, I mean, you've got to worry about clinical quality and being careful with things which are still a bit bleeding edge. There's no doubt about that. But this, part of this process automation thing is actually just wiping out that massive time lag from discovery of better ways to treat people for certain things. In a center of excellence, that yes, that's nice if they can do it, wiping out the gap for disseminating it to everybody, to the whole world. So I think there's so much that can be achieved there. And the other thing is, I mean, there are serious labor shortages in all. I mean, it doesn't matter whether you're in the US or the UK. We only have to read the media, and nobody's got enough nurses apparently. The UK is suffering apparently from a great shortage of docs, and general practice is in a bit of a mess. But I think it's common in all, probably all Western countries, and there's the upside demographic problem, which is meaning a greater care load and a smaller number of, the generation that's actually going to care for the older generation, et cetera, et cetera. So we absolutely have to have ways of making professional care just more efficient in a straight out logistical sense. And so I would imagine that, the most specialized, people like oncologists and cardiologists and so on, wouldn't it be great if we could multiplex their time across a lot of patients? But they need to have a presentation of the patient history and everything to do with the patient the problem that they're being presented with, a very good representation of that, so that they could actually think about it and just focus, right, okay, this person has a certain type of angina or whatever, I know what to do with that, and then right straight on to the next patient. Now that sounds horrible. I mean, people sometimes criticize that, but the fact is specialist care is like taking care of, it's like fixing specific things on your automobile, whereas general practice and community-based care is much more longitudinal and sort of taking care of the patient over time and helping them manage all those specialist interventions. But I think that I don't see any other alternative to that, really.
Yeah, I mean, it feels like we can have the best of both worlds. We can have better, more standardized healthcare by using guidelines gleaned from other organizations and making that whole process much easier to get to. We don't have to lose the humanity of medicine within that. And in fact, what we'd hope is that actually there'd be more time to actually engage with the person, because the process of dealing with their actual care, a lot of which is very repetitive and boring work inside an EHR, that will be done. That sort of stuff is the thing you want to automate away, so that you can spend time actually understanding what the patient is feeling and understanding about their current situation, and spend more time explaining things and make sure they're happy with what they've decided to have done. That's what's to play for, really. But
I
as you
think
say,
so.
I agree that there is an enormous labor shortage. So we do have to reduce some of this duplication of effort and make things a lot more efficient.
Yeah, and there's a few, there's some smart things we can do that just at the technological level. One thing is we need a system that enables healthcare to sort of work in a natural flow. And one way, one co-worker said to me a few years ago, was it has to be, from a physician point of view, do a bit, decide a bit, record a bit. So it's just an ongoing rolling cascade of actions, decisions, recording. Now, how do we take out this extra load of the recording? So that's committing information to the health record. Well, one of the things is obviously modern voice enabling, and that's got a lot of good side effects, because, for example, a team working with a patient with like an actual, like a operating theatre, or they want to maintain a sterile field. We can't be touching stuff that we don't need to touch. If you can do everything with voice, and even have voice recognition of separate people in the room, and you can drive systems that are model based so that the vocabularies are limited to what's relevant at the time. And so I've worked in a team that's actually done all this, and all of that's possible. So there wouldn't be, well, maybe not nothing, but the idea would be, by the time you've got to the end of a procedure or whatever it is you're doing with the patient, there's no sitting down for another half an hour and typing a whole ton of stuff into the health record. It's already done.
Yeah.
So we have to have the concept of workflow that's, handles any mixture of tasks, decision points, and the recording just comes as a side effect by the knowledge of the executing workflow. And because it's all model driven, it knows, semantically where it's at. So I think we need to, have those sorts of things working for us. And I think voice interaction is really going to be the main way. I mean, who knows, maybe there's going to be gestures and eyes or something or other as well, but essentially it's, highly efficient, and it can occur synchronously with the actual work. I mean, the number of, especially surgeons, you say, well, how would you like to interact with an EMR system? They say, well, I'm doing stuff with my hands. It's not going to be that. So either I'm going to be speaking because I can do that, or else I've got to waste another person typing something somewhere. And I don't want to do that if I don't have to, because they've got things to do. So I think there are very nice technological capabilities. And again, we can see there's a lot of potential roles for AI applied in the right way. And decision support built into this, and we've got to solve the problem of explainability and so on. But I mean, there's a lot of exciting things to look forward to, I think. So that's one of the main things that I'm thinking about.
That's been a theme running this kind of YouTube channel, actually, we're only 8-9 episodes in, and the theme of AI, certainly this year, has really taken off in terms of ambient clinical assistance that will notate the content and the summary of a clinical encounter. And the nice thing about that is that the burden of explainability is kind of fairly low, in that you're right there, you were in that conversation. If you read the summary, you are in the best possible position to be able to determine if any of that was hallucinated, if any of that was clinically inaccurate, or if it's misattributed something that you said as something the patient said, or anything like that. You're going to have a fairly good recollection of that. So, as in contrast to some of the crazier end of what people have been suggesting AIs will do, where I think AI wouldn't be safe and isn't ready for, AIs are not ready to drive robotic surgery arms and things like that. We have to, those are the kind of, that's the end where it becomes very risky and the explainability is low. Whereas just taking away a huge burden of administrative tasks is readily achievable, not very expensive, and safe, I think, in most cases. So, you're immediately able to review what's been typed out by the AI and approve it or edit it or whatever. So I think that's a great
structured
option there.
Structured
as well,
note writing, image, analysis, probably to pretty high level of, I mean, there, I've got colleagues who are AI pros, and they in medicine, and they say, we are at the stage where we can just give any ECG or radiology image to AI, at least in the first instance, and we have to have a method of the AI knowing when to say it can't decide, so that a human pro can do it. But the interesting thing is that the thing that humans are really good at is dealing with unknown unknowns. It's just stuff that can't be programmed for, it can't be predicted, and you've just got to use straight out intuition, or whatever mental models you've got to save a situation or to deal with something. And so that's where we want to apply our human power, I think. And wouldn't it be great? And also, there's other basic things, like you mentioned before. If you see a patient, you really do want to spend time with patients, especially people who are like in bed, in patient situation or whatever. They could be fearful, or they might be reacting to medications, or anything could be going on. You actually need to interact with them as a doctor. I mean, I'm telling you what you know much better than I do, of course. But this is what doctors always say to me. Listening to just the patient voice, how they sound, just their general demeanor, if they're perky or if they're the opposite, all those things give you a very good lead on the health state. But if you're wasting all your time typing on a keyboard and looking at a screen, how are you going to do that? So those are the sorts of things that it would be great if clinical professionals can get back to doing. And this whole thing's a two-edged sword as well, because it's easy to imagine if we got this whole thing wrong, and some of the AI hype enthusiasts are to be believed, we'll just replace doctors and everybody else, or maybe the doc will still be there, or the nurse or whoever, but the machine will be doing everything for them. And what would happen if clinical people actually forgot what the next step was, because they would become so reliant on the software just doing the next step? Now, that leads to a question of, how do we guarantee that can't happen? Because that would be a serious problem. And if you think about aviation, how do we stop pilots from falling into that trap? Well, they have to spend a certain number of hours on a simulator every year, and the simulators force them to undergo exceptional situations, and they have to learn how to get back off, do an aborted landing, or deal with a high wind gust, or a wind shift, or some other emergency situation. They have to just do all that stuff in simulators, and they have to pass it, and they can't keep flying if they don't do it. So I actually think that medical professionals, I'd be interested to know your opinion on this, because I just wonder if we need to think about that as a very serious part of this whole future, where we train medical professionals. They learn the basics, but they might be able to think, well, I don't have to remember all of the 15 contraindicated drugs for procedure XYZ. There's a list of those, and I can have it in my system. So I just probably know half of them or something, and the rest, well, I just read it. But I want to, as a professional, be good at dealing with exceptional situations, patient reaction to chemotherapy, or just unexpected bleeding during a birth, or whatever. And maybe we need simulators of, like an actual simulation environment, of the sort that pilots use for flying aircraft.
Well, that's starting to become widespread now. There is a medical simulation community that does exactly this. They provide courses, and a lot of the time that's now part of clinicians' training, sometimes with aids that kind of add realism, so they can put them into a simulated anesthetic room,
Yep.
or a simulated operating theatre, and then there'll be a patient under the drapes, and they try and make it feel as real as possible, so that you don't have to suspend any disbelief there. You can really actually react as though you were actually doing it.
Yep.
And that's getting there. Again, the constraints on that have always been, in the UK certainly, the cost of the simulation centres, and the relative unavailability of the doctors to go and do the simulations, because they're always so busy with their clinical work. But I think I would agree that is an excellent proposition to counter the idea of task skill fade that might happen over time if you're relying on a sat nav of medicine to help keep you on the straight and narrow kind of thing.
Yep.
But yeah, I mean, hugely exciting times, and I think we're all hopeful that openEHR can be part of that future, in terms of modeling the data, and then next stage modeling the guidelines. I think that's a really good point that we could bring it to a close, because I think we've covered a great amount there, and I'd just like to thank you for your time, and thank you for joining us on the show to talk about openEHR. Having a bit of an openEHR season at the moment, so I've just spoken to Rachel Dunscombe, the current CEO of openEHR, and so that will go live soon. And then I've got a couple of other people who are involved in the openEHR community to talk to me about different aspects of the standard, and so there's a couple more episodes to come. And I could finish by just asking you if we can expect to see you on guitar again at the openEHR conference in October.
I'm definitely going to try and get there, so I better practice something, hadn't I? We better
Let's
pick
get
something
worked up. We can rehearse something. We'll rehearse online. We'll try and get something we can do together in the band. That'd be great.
Sounds good. Yeah. Well, thanks for having
Thomas,
me.
thank you so much for taking the time. And
you're welcome.
I'd love to have you back, and we can go into more detail about the prospects of AI and the way that we'll support that in the openEHR standards. So lots of interesting things to talk about. Thank you again, and
Happy
goodbye.
to do it. Thanks for having me.